Okay, let's unpack this. Welcome to the deep dive. Today we are setting a really high bar, actually. We're aiming for an elite, mastery-level understanding of, well, one of the most anatomically dense and technically demanding areas in surgery, esophageal resection.
Absolutely.
This isn't just about, listing facts. We're diving deep into clinical context, fusing that complex anatomy, especially the lymphatics, and the perilous course of the thoracic duct with modern surgical decision-making.
That's the goal.
Our mission is total information immersion for you, the elite professional listening in.
Exactly right. We're essentially translating core surgical texts, key trial data, into knowledge you can actually use, put into context. Because, when a surgeon steps up for an esophagectomy, they're not just cutting tissue.
Yeah.
They're navigating these incredibly vital three-dimensional relationships. You've got the aorta, the airway, the pericardium, the spine. It's all right there. And understanding those relationships, truly understanding them, is the key to minimizing catastrophe.
Yeah, avoiding disaster. So maybe to give us a framework for this deep dive, let's start by outlining the three core surgical concepts that all this anatomy feeds into. These are the procedures we're really trying to master today.
Okay, good idea. These are really the anchors of the field, you could say. First, there's the historically standard transthoracic esophagectomy. Many still consider it the gold standard for getting a thorough lymph node clearance.
Right, the classic approach.
Then second, you have the increasingly optimized, minimally invasive esophagectomy, or MIO. The big push there is trying to reduce the patient's recovery burden.
Makes sense. And the third?
And third, underpinning both of those, is successful thoracic lymphadenectomy. This isn't really optional. It's the fundamental component that dictates oncological success, regardless of how you get there.
Okay. Foundations first, then. Mastery demands we start right at the beginning. Let's ground ourselves in the embryology. How does the esophagus actually form initially, and what's the critical error that leads to those well-known congenital problems?
Okay, so the esophagus and the trachea, too, they both originate from the primitive foregut. Specifically, there's this ventral diverticulum, a little outpouching, that appears around the third week of gestation.
Third week, okay.
And critically, it starts as a single common tube running head to tail, craniocaudal. It's shared between what will eventually become the gastrointestinal tract and the respiratory system.
Ah, so they start fused together. Separation is the key event then.
Precisely. The respiratory bud develops from this common tube, starts to grow out, and then it begins to cleave, separate longitudinally. It forms the tracheobronchial tree anteriorly towards the front.
And if that separation fails...
That's where the problems arise.
Yeah.
If that division fails, either partially or, completely, the result is that devastating spectrum of congenital issues. Things like esophageal atresia, where the esophagus just ends blindly.
Right.
Often coupled with the tracheoesophageal fistula, which is that abnormal connection between the two tubes.
And that initial common blueprint, it explains why problems in one system congenitally almost always seem to involve the other. We sometimes even see the leftovers of this development in adult surgery, right? Like foregut duplication cysts.
Yes, exactly. You do see those. They're typically found in the posterior mediastinum, behind the heart. They're distinct entities, but because they share that common origin, they often share a wall or maybe a muscle layer with the esophagus.
But they're not usually connected inside, are they?
That's the key detail. They are rarely continuous with the actual esophageal lumen itself. That's thanks to the complete separation of the original tubes during development. Usually, they only become a problem requiring intervention if they grow large enough to compress adjacent structures, airways, the heart, or maybe cause significant reflux symptoms.
Okay, so moving from that blueprint to actual practice, let's orient ourselves as the surgeon. For the standard open, right-sided approach, how is the patient positioned and what surface markers are guiding that initial incision?
All right, the standard open way is a right-sided thoracotomy. Usually you'll position the patient in a left lateral position, so they're lying on their left side.
Okay.
And the initial cut, the incision, it's guided by surface landmarks.
Right.
Roughly, you're aiming between the nipple anteriorly and the tip of the scapula, the shoulder blade, posteriorly.
And the choice of intercostal space. That's never random in thoracic surgery, is it? Why the fourth intercostal space? Why is that usually recommended for esophagectomy thoracotomy?
It's all about exposure, getting the best view. It's a strategic choice. Entering the fourth ICS, the fourth space between the ribs. generally allows the best working access to pretty much the entire mid to lower thoracic esophagus.
Ah,
It gives you easy access to both the infrazygous segment, that's the lower two-thirds, and the supraesophageal segment, the upper third above the esophagus vein. It just optimizes your visual field for that radical lymph node dissection, the lymphadenectomy.
and you mentioned a really interesting technical point earlier, linking this incision directly to managing pain after the operation.
Ah, yes. Post-thoracotomy pain is a major issue, a big component of morbidity. So for pain reduction, the technique involves ligating and actually excising the intercostal neurovascular bundle, the nerve, artery, and vein running under the rib, but specifically on the aspect inferior to the wound, so below the incision.
Inferior.
Doing that seems to reduce the incidence of that persistent neuralgia, the nerve pain, that patients often get with this approach.
Right. Now let's start tracing the path of the esophagus itself through the chest, the thorax. Where does it enter and what's its initial relationship to the vertebral column and the trachea?
So when it comes down from the neck into the chest, it's immediately positioned posterior to the trachea, behind the windpipe.
Yep.
And importantly, it's consistently anterior to the vertebral column in front of the spine.
Got it.
It descends within the posterior mediastinum, that space behind the heart, which runs roughly from the tracheal bifurcation where the trachea splits around T4, T5,
Okay.
down to about the T12 vertebral body.
And its relationship with the big vessels, the aorta specifically, that changes as it goes down, doesn't it?
Correct. Superiorly, higher up, it runs mostly along the right side of the descending thoracic aorta. That's often where you start mobilizing it. But as it descends toward the diaphragm, it gradually curves or inclines to the left.
It crosses over.
It crosses anterior to the aorta in front of it, and it finally passes through the esophageal hiatus, the opening in the diaphragm, usually at the level of T10, to get into the abdomen.
Okay, let's detail the structures that lie directly anterior to the thoracic esophagus. These are the things the surgeon needs to be constantly aware of during that mobilization. Let's go top down.
Okay, top-down anterior relations. First, the trachea superiorly. Then just below that, the right pulmonary artery. Further down, critically, the left principal bronchus, the main airway to the left lung, lies anteriorly.
Very close relationship there.
Extremely close. Inferiorly, the pericardium, the sac around the heart, forms a very close anterior relationship. That pericardium separates the esophagus from the posterior wall of the left atrium of the heart, and finally the diaphragm is the most inferior anterior relation within the chest.
That proximity to the left atrium sounds particularly hazardous.
It really is. Any thermal injury from cautery or even mechanical injury during dissection right there, it can have immediate and devastating cardiac consequences. You have to be incredibly careful.
And turning now to the posterior relations, the space that surgeon is developing to get that en bloc resection, taking everything out together, what's back there? What defines that posterior plane?
Posterior, well, you have the vertebral column itself and the longus colli muscles running along the front of it. Vascular structures back there include the right posterior intercostal arteries.
Yeah.
These actually supply blood to the esophagus, so they need careful handling.
Right.
Then there's the esophagus vein, a major vein running up the right side, and the terminal parts of the hemiazygos and accessory hemiazygos veins coming across from the left. Near the diaphragm, the aorta shifts to become posterior.
Okay.
But arguably, the most critical and most hazardous structure in this whole posterior field, running just lateral to the esophagus vein, that's the thoracic duct.
That's the perfect transition because the thoracic duct really demands its own deep dive, doesn't it?
Yeah.
When we talk about complications like chylothorax after surgery, we're talking about failing to manage this duct anatomically. What's fascinating, as you hinted, is its unusual origin and path, starting way below the surgical field.
It really is fascinating. Its origin is deep down in the abdomen, usually around the level of the L1 or L2 vertebrae. This is where the right and left lumbar lymphatic trunks, draining the lower body and legs, condense with the intestinal trunk, draining the gut. They merge to form this dilation, this sac, called the cisterna chyli.
Cisterna chyli, right.
That marks the starting point for pretty much all the main lymphatic return back to the systemic circulation from below the diaphragm.
So how does this massive lymphatic vessel get from the abdomen up into the chest, into the field of operation?
It enters the thorax right alongside the aorta. It passes through the aortic diaphragmatic hiatus, the same opening the aorta uses to get through the diaphragm.
Okay.
Once it's inside the chest, its course is quite specific. It ascends within that posterior mediastinum, typically situated between the aorta on its left and the esophagus vein on its right.
And relative to the esophagus itself?
Critically, its position relative to the esophagus is posterolateral. It's behind and slightly to the side. This means that during the posterior mobilization of the esophagus, when you're lifting it forward, the duct is essentially being rolled forward with the specimen.
Ah, which makes securely ligating it absolutely essential.
Non-negotiable in an open or transthoracic procedure.
That posterolateral path, though, it sounds like it could be tricky, maybe not always perfectly parallel to the esophagus. And where does this whole system eventually drain? Where does all that lymph fluid end up?
It tracks all the way up the chest, and then near the top, around T4, T5, it crosses over to the left. It curves posterior behind both the left carotid artery and the left internal jugular vein. And it finally drains into the systemic venous system, right at the angle formed by the confluence, the joining of the left subclavian vein and the left internal jugular vein.
The left venous angle, okay.
That spot is the endpoint for almost all the lymphatic drainage from the entire body below the diaphragm and the left side of the head, neck, and arm.
Wow. Okay, so this highlights a really significant difference between surgical approaches then. If we're talking about the transhiatal approach, which relies more on that blunt dissection, is the surgeon deliberately trying to preserve the duct, or are they just hoping they miss it?
That's a great question. The transhiatal approach involves a blind, blunt dissection up in the mediastinum, using fingers or instruments without direct vision of everything. Because the surgeon doesn't have that direct view of the posterior mediastinum like in a thoracotomy.
Right.
The duct is typically not ligated as a specific separate step. The assumption, or maybe the hope, is that by staying very close to the esophageal wall, any small lymphatic branches are sealed off by the trauma of dissection. Or perhaps the main duct itself just gets pushed safely aside.
But that sounds inherently risky.
It carries a risk. In a transthoracic or MIO approach with thoracoscopy, securing the duct, identifying it, ligating it, dividing it, is a mandatory, deliberate step. It's done specifically to prevent that catastrophic postoperative leak of chyle, a chylothorax. This difference in managing the duct is actually a major point of criticism regarding the oncological safety profile of the traditional transhiatal approach.
Right, that makes sense. Let's pivot now to the overarching surgical principles. Regardless of the approach, open, MIO, transhiatal, the oncology dictates three absolutely essential components for success.
Yes, the mission is clear on these 3 points. First, you must achieve an R0 resection. That means completely clear surgical margins, verified under the microscope by the pathologist, no cancer cells left at the edge.
R0, critical.
Second, meticulous and thorough removal of all the draining lymph nodes. That's the lymphadenectomy we keep mentioning. And third, the creation of a healthy, well-perfused, and crucially, a tension-free gastric conduit, usually the stomach pulled up to restore the ability to swallow.
Healthy, tension-free conduit.
Okay. Failure in any one of these areas seriously compromises the patient's long-term survival chances.
Focusing on that R0 margin for a second, what's the specific proximal margin, the margin towards the mouth, that's required? And why is that measurement different depending on whether the tissue is still in vivo in the body versus ex vivo on the pathology bench?
Good question. The standard goal for that proximal margin is 5 centimeters in vivo. That number comes from robust data showing that 5 centimeters significantly minimizes the risk of local recurrence right at the anastomosis, where you join things back together. And achieving it acts as an independent predictor of overall survival.
5 centimeters in vivo.
In vivo. The reason the measurement changes is because of tissue retraction after resection. Once the esophagus is removed, the muscle pulls back, it shrinks. So that 5 centimeter margin measured in vivo often equates to only about 3.8 centimeters ex vivo on the bench.
Ah, okay.
Which is why pathologists need to be aware of this discrepancy when they're measuring the specimen. The surgeon aims for 5 centimeters, the pathologist might measure less.
Right, communication is key there. Now let's dissect the actual approaches. Start with the classic transthoracic oesophagectomy, the standard 2-phase operation.
Okay, the traditional transthoracic. It typically requires 2 distinct phases or stages. Phase 1 is usually a midline laparotomy, an incision down the abdomen that's used to mobilize the entire stomach, fashion it into a tube, a gastric conduit, and clear out the abdominal lymph node basin. That's the D2 clearance.
Okay, abdomen first.
Then, phase 2 involves repositioning the patient and doing the right posterolateral thoracotomy, opening the chest. Through that incision, the thoracic esophagus is dissected out, the thoracic lymphadenectomy is completed, and the gastric conduit that was prepared earlier is pulled up into the chest to create an intrathoracic anastomosis, joining it to the remaining esophagus inside the chest.
Got it. Two big phases. Now, how does the transhiatal approach differ in its execution, given that it specifically avoids opening the chest?
The transhiatal also starts with a laparotomy for gastric mobilization, just like the first phase of the transthoracic. But then, instead of opening the chest, the surgeon works upwards through the esophageal hiatus, that opening in the diaphragm.
Through the diaphragm.
Exactly. They only have direct vision maybe up to the level of the inferior pulmonary ligament. Then comes the critical step, the transition to blunt dissection. The surgeon uses their hand, or sometimes instruments, to blindly sweep the esophagus off the structures behind it, the vertebral bodies, the major vessels in the posterior mediastinum.
Blind dissection. That sounds challenging.
It is. And because the top end is freed blindly, a separate cervical incision in the neck is required to mobilize the upper esophagus and perform the final anastomosis up in the neck.
Neck anastomosis for transhiatal.
Okay.
And what about the three-phase approach? When is that even more extensive operation justified?
The three-phase approach is essentially the standard transthoracic operation laparotomy plus thoracotomy, but with the addition of a third mandatory cervical incision and neck dissection.
Okay.
This is generally reserved for tumors located higher up in the esophagus, typically squamous cell carcinomas. In these cases, the risk of metastatic spread to the neck lymph nodes is considered high enough to mandate a formal cervical lymphadenectomy for adequate oncological clearance.
Higher tumors, squamous cell, risk of neck mets.
Got it. We also briefly touched on the left thoraco-abdominal approach. Can you describe that incision and the key surgical challenge relating to the diaphragm?
Yeah, this one's used less frequently nowadays, usually reserved for very large tumors in the lower third of the esophagus or at the junction. The incision is oblique, starting below the tip of the scapula and running downwards and forwards, entering the chest, usually via the sixth intercostal space.
Okay.
The big challenge here is the diaphragm. It has to be divided circumferentially to get exposure, to avoid denervating the main muscular part of the diaphragm, which would severely compromise breathing post-op.
Right, you need the diaphragm to work.
Absolutely. The incision in the diaphragm must be made at least 3 centimeters away from the chest wall attachment to preserve the phrenic nerve branches. The anastomosis in this approach is performed intrathoracically, but typically below the arch of the aorta. Okay, 3-centimeter margin on the diaphragm division. Now, the choice of approach, as you hinted, is heavily dictated by the tumor's identity, its histology. Let's compare adenocarcinoma and squamous cell carcinoma in terms of location and spread.
Right. Adenocarcinomas are now the most common type in Western countries. They typically arise in the lower esophagus and at the esophagogastric junction, the OGJ. Their lymphatic spread pattern is usually caudal, meaning downwards toward the abdominal nodes.
So less likely to go up to the neck?
Much less likely.
Yeah.
Which is why the three-phase approach with its neck dissection is generally not considered standard for adenocarcinoma in Western practice.
But squamous cell carcinoma,
Yeah.
That's the one associated with skip metastases and upper nodal involvement, right?
Exactly. Squamous cell cancers tend to occur higher up in the esophagus. They are notorious for a higher rate of neck nodal metastases, sometimes up to 50% in upper tumors. And they have this characteristic risk of skip metastases.
Skip metastases, meaning?
Meaning the cancer cells can jump over intermediate lymph node stations and appear in nodes further away, non-contiguously. For instance, you might find involved nodes high in the chest or neck, even if the nodes right next to the tumor seem clear.
Wow, that makes clearance much harder.
It absolutely does. It makes a standard two-field abdomen and lower chest lymphadenectomy potentially inadequate, hence the push, particularly in Asian centers where squamous cell is more common, for a 3-field dissection in these cases.
This necessity for precise location brings us neatly to the SEERT classification for those junctional tumors, right at the OGJ. How do type 1, type 2, and type 3 define the anatomical reality for the surgeon?
The SEERT classification is all about defining the tumor's epicenter, its main bulk, relative to the anatomical esophagogastric junction where the tubular esophagus meets the stomach pouch.
Okay.
SEERT type 1 tumors have their center more than 1 centimeter above the junction, but within 5 centimeters of it. These are essentially distal esophageal cancers that might just creep into the gastric cardia.
Type 1, mainly esophageal.
SEERT type 2 tumors are the true junctional cancers. Their epicenter is right at the junction, typically defined as being within 1 centimeter proximal above or 2 centimeter distal below the junction line.
Type 2, truly junctional.
And SEERT type 3 tumors have their center below the junction, between 2 and 5 centimeter distal to it, but they invade upwards across the junction into the esophagus. These are essentially subcardial gastric cancers behaving aggressively upwards.
Type 3, mainly gastric, invading up. Okay.
Right.
And that classification directly impacts staging now, right? I remember there was a crucial update around 2010.
Yes, that was a major philosophical shift. Since the AJCC-UICC's 7th edition staging system came out in 2010, all junctional tumors, regardless of serotype, are staged using the esophageal cancer staging system, not the gastric one.
Why had it change?
It reflects the recognition that the biology, the aggressiveness, and the outcomes of these junctional tumors align much more closely with esophageal cancers than typical gastric cancers further down the stomach.
Interesting. But does that staging always dictate the operation? Is there still debate?
Oh, absolutely. There's still significant clinical debate, especially around type 3. Even though they're staged as esophageal cancer, many surgeons, particularly gastric surgeons, argue that their primary lymphatic drainage pattern is still predominantly gastric downwards.
Yeah, okay.
So they might advocate for a total gastrectomy with a more limited esophageal resection and a D2 abdominal nodal clearance, rather than a full two-phase esophagectomy with a thoracic dissection. The CERIC grading often ends up guiding whether a specialist esophagogastric surgical oncologist or a predominantly gastric surgeon takes the lead on the case.
Here's where it gets really interesting. Let's dive into the MIO versus open outcomes debate. Minimally invasive esophagectomy. We identify the two main strategies, Ivor Lewis and McCune. Remind us of the fundamental difference between those two MIO approaches.
Yeah, the key differentiator is simply the location of the anastomosis, where you reconnect the GI tract. The MIO Ivor Lewis approach uses laparoscopy for the abdominal part and then thoracoscopy, or perhaps a limited thoracotomy, for the chest part. It culminates in an intrathoracic anastomosis made inside the chest cavity.
MIO Ivor Lewis. Chest anastomosis.
Right. The MIO McKean uses thoracoscopy for the chest dissection and then usually laparoscopy or a limited laparotomy for the abdominal part. But the reconstruction, the anastomosis, is achieved via a separate cervical incision in the neck. So it results in a cervical anastomosis.
MIO McCune.
Yeah.
Neck anastomosis. Got it. Now, early reports really favored MIO, didn't they? Citing reduced trauma, shorter recovery. What kind of metrics were people seeing in those large early series?
They were very compelling initially. We saw reports showing decreased overall morbidity, fewer complications, and notably shorter hospital stays, sometimes as low as 8 days in some big, high-volume MIO series.
8 days is impressive after such major surgery.
It really is. It suggested a powerful benefit in accelerating recovery, which is critical, especially given the known pulmonary consequences of major open chest surgery. Less pain, better breathing.
However, when the broader data started coming in, from multiple centers pooling their results like through the esophagectomy complications consensus group ECG database, the shine seemed to come off a little bit. What does that data tension tell us about how generalizable MIO outcomes really are?
Yeah, the ECCG data, which synthesized information from 24 high-volume international centers, painted a slightly different picture. It suggested that across current surgical practice, when you look at the big picture, there's actually no significant difference in overall complication rates or length of hospital stay between the open and the MIO approaches overall.
Really? No difference. Why might that be?
Well, it likely reflects a couple of things. First, the steep learning curve required for MIO. It's technically very demanding. Second, the fact that high-volume centers performing open procedures have also dramatically optimized their pathways, enhanced recovery protocols, better pain management.
Ah, so the open outcomes got better too.
Exactly. To the point where, in expert hands, the outcomes might be nearly equivalent now in terms of lengths of stay and overall morbidity, though maybe not pulmonary morbidity specifically.
Okay, that brings us to the core oncological question. Is MIO truly equivalent in terms of cancer cure? If we know or suspect that fewer lymph nodes are often removed, how do we know we aren't compromising long-term survival?
That is the million-dollar question, and honestly, it's still a gap in our knowledge.
Yeah.
We still lack definitive, high-level randomized controlled trials, RCTs, proving that MIO improves or even just maintains equivalent long-term oncological survival compared to open surgery.
No big RCTs on survival yet.
Not specifically powered for that.
Yeah.
And meta-analyses that have compared MIO and open using case control studies or registry data have pretty clearly demonstrated that, on average, fewer lymph nodes are resected in the MIO group.
And the impact of that.
Well, the direct impact of that reduced nodal yield on survival is still unknown, officially. But historically, in cancer surgery, fewer nodes retrieved often means potentially poorer staging accuracy and maybe a compromise of local regional disease control. It's a concern.
But you mentioned the morbidity picture, IS, clearly better in one key area, breathing, pulmonary function.
Absolutely. This is probably the strongest argument for MIO right now. There was one highly influential RCT specifically focused on postoperative recovery, and it reported a massive benefit. significantly fewer postoperative respiratory tract infections in the MIO group. It was something like 12% in the MIO group versus 34% in the open group.
Wow, that's a huge difference. 12% versus 34%.
It's a dramatic reduction. That reduction in pulmonary complications is arguably the most compelling reason to favor the MIO technique right now, maybe even regardless of the nodal yield debate for some patients.
Okay. Speaking of technical innovation, let's touch on robotics. Robot-assisted MIO. Early data suggested maybe some concerning issues, relatively high leak rates, even airway injuries. Is this purely the learning curve, or is there maybe an inherent trade-off with the technology itself?
It seems like it's probably a bit of both, honestly. The initial data, particularly from centers just starting out with robotics, did show a concerning trend towards higher rates of anastomotic leaks, more reoperations, and even some airway trauma.
Why would that be?
The fundamental issue that gets debated here is the loss of haptic feedback. With the robot, the surgeon can't directly feel the tissue tension or resistance in the same way they can with open or even standard laparoscopic instruments.
No sense of touch.
Exactly. You're trading that tactile sensation for, admittedly, superior 3D visualization and wristed instrument control. But that trade-off, especially early on, can lead to subtle errors in tissue handling, maybe applying too much tension or misfiring a stapler.
But is it getting better?
Yes. As large single-center programs gain more experience publishing their later series, those complication rates are falling dramatically. This strongly suggests that much of the initial high rate was indeed a function of that steep learning curve inherent to adopting such complex technology. But the lack of haptics remains a factor to consider.
Okay. Now let's tackle that other major comparison. Transthoracic versus transhiatal. We know transhiatal generally has less immediate morbidity because you avoid the thoracotomy. But how does that critical issue of locoregional control, the lymph node clearance, play out in the definitive trials?
Right, the transhiatal approach has always had that appeal, less initial hit on the patient, avoiding the chest incision. But as we discussed, the blind nature of the mediastinal dissection makes its oncological radicality questionable, especially for nodes high up.
So what did the studies show?
Well, an initial meta-analysis looking back at dozens of older studies suggested maybe no difference in 5-year survival overall. But frankly, many of those studies lacked robust methodology. They weren't randomized.
So we need better evidence. We need the gold standard trial.
Exactly. Which brings us to the Holscher and Onlu trial, published in the New England Journal of Medicine. They randomized 220 patients to either transthoracic or transhiatal oesophagectomy.
Okay, the definitive comparison. What was the headline finding, and what was the crucial nuance for those Seward type 1 tumors?
The headline finding was actually quite reassuring, in a way. There's no significant difference in overall operative mortality, which was low in both groups, around 2% and 4%, or in overall 5-year survival, 34% for transhiatal versus 36% for transthoracic.
So overall survival, pretty much the same.
Pretty much the same. And encouragingly, the transhiatal group did have fewer pulmonary complications, as expected. But, and this is the crucial insight, when they did a subgroup analysis looking specifically at the patients with node-positive Seward type 1 tumors, remember, those are the ones centered just above the junction, the transthoracic approach provided significantly improved locoregional disease-free survival. The difference was shocking. 64% disease-free locally for transthoracic versus only 23% for transhiatal at 5 years.
Wow, 64% versus 23%. That's a massive difference in controlling the cancer locally for that specific group.
It's a huge difference, a 41% absolute difference in locoregional control.
What's the surgical implication of that? Why did those type 1 node-positive patients do so much worse locally with the transhiatal approach?
The clear implication is that for these slightly higher junctional tumors, which has a propensity to involve lymphatics up near the subcarinal region, station 107, and maybe around the left main bronchus, station 109, the blind transhiatal dissection simply cannot achieve adequate clearance of those nodes.
It just can't reach them properly.
Exactly. The transthoracic approach, allowing direct visualization and meticulous dissection of these specific nodal stations, proved oncologically superior in controlling the local disease for those specific patients. It strongly suggests that for certain upper OGJ tumors, particularly if node positive, the transthoracic approach remains oncologically mandatory. Unless, perhaps, neoadjuvant therapy, like chemoradiation given before surgery, has completely sterilized those node beds.
That connects directly to the findings from the Big Cross trial, doesn't it? Didn't that trial suggest that adding neoadjuvant chemoradiotherapy before surgery actually seemed to negate the survival advantage previously seen with the more extensive transthoracic lymphadenectomy?
Precisely. The interpretation of the cross-trial results is that the preoperative treatment is likely effective at eradicating micrometastatic disease in those locoregional nodes, including the ones that are harder to reach via transhiatal or even MIO approaches.
So if the pre-op treatment clears the nodes,
Then the argument becomes, if the nodes are likely sterilized, maybe the dominant factor determining the best approach shifts back towards minimizing morbidity. In that case, the pulmonary benefit of a less invasive approach like transhiatal or MIO might outweigh the need for the most extensive possible nodal dissection offered by the open transthoracic approach.
but if the patient is going straight to surgery without neoadjuvant treatment,
Then the oncological benefit of that thorough transthoracic dissection, especially for potentially node-positive Seward type 1 or higher tumors, likely remains critical.
okay, that clarifies the trade-off significantly. Let's move now into the mechanics of the lymphadenectomy itself. This is where anatomical mastery is truly put to the test. We often hear about two-field versus three-field clearance. Can you define those fields by region, not just by listing all the station numbers?
Sure. The two-field standard lymphadenectomy focuses on clearing two primary anatomical regions. First, there's comprehensive abdominal clearance. This includes the nodes right around the stomach, perigastric, nodes along the celiac artery axis, the splenic artery, the campatic artery, basically the standard D2 gastric cancer nodal clearance.
Abdomen, D2 clearance. Okay. Second field.
The second field is the infraoesophagus thoracic clearance. This means removing all the lymph node tissue in the chest located below the arch of the oesophagus vein. This encompasses nodes along the lower esophagus, the periaortic nodes down low, and crucially, the subcarinal nodes, station 107, and parabronchial nodes, 109, 110, 111, 112.
Below the azygos arch. Got it. So the more aggressive three-field clearance adds, what, two crucial regions on top of that?
The three-field technique extends the dissection upwards significantly. It adds the supraesophageal field, which includes the high paracesophageal nodes above the azygos arch, and importantly, the nodes around the recurrent laryngeal nerves, stations 105 and 106.
Suprasygos. Okay. And the third field.
And critically, it adds the cervical field. This involves dissecting the lymph nodes in the neck, specifically the lower cervical paraesophageal nodes, station 101, and the supraclavicular nodes, station 104.
Okay, so abdomen, infraazygos, supraazygos, and cervical makes it three fields. Now, the significance of finding cancer in those neck nodes, it changed fundamentally with that TNM staging shift we mentioned earlier. Can you explain that philosophical change again?
Yeah, it was a big deal. Historically, under the 6th edition of the AJCC staging system, finding cancer in neck nodes, classified as M1A, was considered distant systemic metastatic disease. It essentially meant the disease was often deemed incurable with surgery alone.
Right, stage 5E equivalent.
Exactly. But the 7th edition radically altered this view. It recognized that biologically involved lymph nodes are involved lymph nodes, regardless of their anatomical location relative to the primary tumor. The focus shifted entirely to the number or the total burden of involved nodes.
So location matters less than quantity.
Precisely. Whether a cancerous node is found in the abdomen, the chest, or the neck, the prognosis is now primarily dictated by the total count of positive nodes, reflecting the overall disease burden, rather than automatically classifying neck involvement as distant mets.
Okay, so if the anatomical location of the nodes doesn't determine the M stage as much as the burden does, why does the tumor histology, squamous versus adeno, still seem to drive the decision between doing a two-field versus a three-field dissection so strongly?
It comes down to probability and pattern of spread. For squamous cell carcinoma, particularly those arising in the upper or mid-thoracic esophagus, the data, especially from large eastern series where this histology is more common, shows very high rates of neck nodal metastases, sometimes approaching 50% for upper third tumors.
So you basically have to assume they might be there.
Exactly. If you perform only a two-field dissection in that scenario, you have a very high chance of leaving known metastatic disease behind in the neck. Therefore, for upper mid-squamous cancers, a three-field dissection is often considered the standard of care, particularly in Asia, to ensure adequate clearance.
And for adenocarcinoma?
For adenocarcinoma, which tends to arise lower down and spread caudally, neck node involvement is much less common. However, if you do find involved neck nodes within adenocarcinoma, it generally implies a very heavy overall burden of disease, meaning lots of positive nodes elsewhere too. In that situation, the poor prognosis is driven by the high volume of disease, not necessarily the specific fact that it reached the neck. The finding itself might push towards palliative intent.
Got it. Now, given that our current staging technology, things like PTCT scans and endoscopic ultrasound, EUS, still struggles to reliably detect tiny micrometastases in these lymph nodes. The surgeon is often forced to make a difficult decision, weighing the potential benefit of a wider dissection against the increased risk. What is the major morbidity trade-off associated specifically with adding that third field, the neck dissection?
The risks definitely increase with the three-field approach. It's inherently a longer, more complex operation. The need for a cervical anastomosis, joining the conduit in the neck, carries a higher risk of anastomotic leaks and also long-term strictures, or narrowing, compared to an intrathoracic anastomosis.
Leak and stricture risk higher in the neck.
Yes, but the dominant hazard, the complication that can cause the most significant long-term disability, is the risk of injury to the recurrent laryngeal nerve, RLN, during the dissection of those supraesophageal and cervical lymph nodes.
RLN palsy. Let's detail the impact of that. This isn't just a hoarse voice, is it?
Not at all. It's far more serious. RLN injury, whether temporary or permanent, results in paralysis of the vocal cord on that side. This leads directly to dysphonia, a weak, breathy voice, but more importantly, it severely impairs the ability to cough effectively and protect the airway.
Leading to aspiration.
Exactly. Chronic aspiration of saliva and food particles is a major risk, often leading to life-threatening aspiration pneumonia. It can necessitate prolonged mechanical ventilation after surgery, significantly extend ICU stays, sometimes lead to chronic respiratory failure, and it drastically limits the patient's long-term exercise tolerance and overall quality of life.
Sounds devastating.
It can be. So the surgeon has to carefully balance the potential oncological benefit of clearing potentially involved neck nodes against this very real risk of severe permanent functional impairment.
Okay, let's get highly technical now. Can you walk us through the sequential steps of the infraazygos dissection, the part below the azygos arch, typically done via a right thoracotomy? Where does that dissection usually begin, and what are the immediate landmark divisions?
Sure, the mobilization usually begins inferiorly, down near the diaphragm. The first step is often dividing the inferior pulmonary ligament. This is a fold of pleura tethering the lower lobe of the lung. Dividing it, extending the division superiorly right up to the level of the inferior pulmonary vein, allows the lung to be retracted anteriorly out of the way, fully exposing the posterior mediastinum where the esophagus lies.
Okay, ligament down, lung retracted. What's next? The azygos vein arch. That must need dealing with early to get exposure higher up.
Absolutely. The azygos arch, where the vein curves forward over the lung root to drain into the superior vena cava, is usually the next major structure to address. It needs to be ligated and divided.
How do you do that safely?
With extreme precision. It's crucial to preserve the underlying intercostal artery, which often runs immediately deep to the vein at that point. Also, you have to be meticulous about securing any small venous tributaries flowing into the arch right where you ligate it. A loose ligature on one of those can untwist after you've moved on and lead to a massive delayed hemorrhage back into the chest. Very dangerous.
Wow, okay. Azygos arch ligated and divided carefully. Now the posterior structures are revealed, including the thoracic duct. We need to focus on identifying it and that mandatory ligation we talked about.
Right. With the azygos arch down and the esophagus retracted medially towards the middle, and the aorta forming the posterior limit of dissection, the thoracic duct should become identifiable. Remember, it runs lateral to where the azygos vein was, and generally posterolateral to the esophagus itself.
Posterolateral, okay.
It often looks like a thin-walled, sometimes glistening structure. It's absolutely critical that the duct is identified and ligated securely at its inferior end. The ligation point should be 3 to 5 centimeters superior to the diaphragmatic hiatus.
Why that specific location, 3-5 centimeters above the hiatus?
That height ensures you're catching it above where major lymphatic branches draining the upper abdomen might join it as it comes through the diaphragm. It helps prevent leaving a major inflow tributary below your ligature.
And that detail you mentioned earlier about the number of ducts, that cannot be overstated here, can it?
No, it really can't. It's the ultimate anatomical pitfall, the warning sign. The thoracic duct system is highly variable between individuals. In approximately 65% of the population, the thoracic duct system is not a single tube. It might comprise 2 or even up to 3 separate major ducts, or sometimes a dense network or plexus of channels.
65% have variations. That's more common than not.
It is, which means the surgeon must actively look for and securely ligate every significant lymphatic trunk they encounter in that area. Missing even one major duplication or large branch leads directly to a persistent postoperative chylothorax.
A vigilant search for multiples is key. Now, what defines the limits of that posterior plane dissection? How do we protect the aorta back there?
The descending thoracic aorta serves as the unwavering posterior boundary. The surgeon must stay anterior to it. You need to take care not to dissect too far laterally behind the vertebral bodies. Going too wide there not only risks injuring the segmental artery supplying the spinal cord, but is also generally unnecessary for oncological clearance of the esophageal nodes.
Stay anterior to the aorta.
Yes. And those small arterial branches, the esophageal feeders that come directly off the aorta to supply the esophagus, those must be identified, meticulously clipped or ligated right at their origin, and divided to prevent troublesome postoperative bleeding from that posterior wall.
Okay, now let's move superiorly, above the divided azygos arch to the supraazygos dissection and that critical RLN hazard zone. How is the plane developed higher up, and where exactly does that left recurrent laryngeal nerve run?
Once the azygos arch is down, the dissection continues upwards, developing the plane between the mobilized esophagus medially and the trachea anteriorly. This is the field where the most delicate lymph node dissection occurs, around the upper esophagus and airway.
And the nerve?
The left recurrent laryngeal nerve, or LN, is the structure you absolutely have to protect here. It runs right within the tracheoesophageal groove. It's tucked tightly in the corner between the trachea and the esophagus on the left side.
Right in the groove.
Right in the groove. It must be actively identified, gently dissected free from the surrounding nodal tissue, and meticulously preserved throughout the supraazygos dissection. The right RLN has a different course, looping around the right subclavian artery much higher up, so it's usually less directly in the main thoracic field, but the surgeon still needs to be mindful of it, especially considering the rare anatomical variant of a non-recurrent right RLN, which can arise lower down.
This supraazygos area is also where those key nodal stations, 107 subcarinal and 109 parabronchial, are removed. You mentioned earlier that standard thermal dissection methods like electrocautery are dangerously unsuitable here. Why is that?
Because the tissue plane, separating these lymph nodes from the back wall of the trachea, the membranous portion, or the main stem bronchus, is extraordinarily thin. It's flimsy. Any significant thermal injury, like using diathermy or electrocautery, to control bleeding right on that surface. Risks causing full-thickness necrosis, death of the airway wall tissue. This could potentially lead to a massive, life-threatening post-operative tracheoesophageal or bronchoesophageal fistula, an absolute disaster.
So how do you manage bleeding there?
Bleeding control in this specific delicate area must be achieved using non-thermal methods, meticulous individual clip application on small vessels, or perhaps very fine suture ligation. You simply cannot risk burning the airway.
Okay, that's a critical technical point. Let's move to the final step, reconstruction, creating the anastomosis. Success here is often judged by two key postoperative outcomes: minimizing the anastomotic leak rate and minimizing the long-term stricture rate. What are the inviolable principles for making a good join?
The principles are pretty universal for any intestinal anastomosis, but especially critical here. First, the gastric conduit you've created must have an excellent blood supply. It has to be well vascularized right to the tip.
Good blood supply.
Second, any potentially ischemic or poorly perfused edges of the conduit or the remaining esophagus must be resected back to healthy bleeding tissue. And third, the final anastomosis, the joint itself, must be absolutely tension-free. Any tension on that suture line or any compromise in blood supply dramatically increases the risk of it breaking down, leading to a leak or scarring down, causing a stricture.
Well vascularized, healthy edges, tension-free. Got it. Now let's compare the actual techniques. We hear about hand-sewn anastomoses, circular stapled ones using an EEA stapler, and linear stapled techniques. Does the evidence show one is clearly superior?
It's interesting. Meta-analyses comparing traditional hand-sewn versus circular stapled techniques using that end-to-end stapler have historically shown no significant difference in leak rates between the two.
Hand-sewn versus circular stapled, similar leak rates.
Pretty much. However, there's growing evidence favoring a different technique, the linear stapled anastomosis. This often involves creating a side-to-side join or a functional end-to-end anastomosis using linear staplers. Several studies and meta-analyses looking at this technique have shown a significant decrease in both anastomotic leaks.
Both leaks and strictures.
Yes, both leaks, with the reported risk ratio around 0.51, meaning roughly half the risk, and also a decrease in subsequent stricture formation, risk ratio around 0.56 when compared to hand-sewn techniques.
Why might the linear stapler be better?
The thinking is that the controlled, reproducible compression applied by the linear stapler jaws might create a more reliably uniform and robust anastomosis with less tissue trauma compared to individual sutures. It seems to provide a more consistent result.
Interesting. And what about that mitigation strategy we touched on earlier? The sort of insurance policy surgeons can employ regardless of the technique they use.
Ah, yes, the omentum. If sufficient omentum, that fatty apron attached to the stomach, is available and can be preserved on its blood supply, usually the gastroepiploic vessels, when creating the gastric conduit,
Right.
it can be mobilized and wrapped around the newly formed anastomosis like a protective blanket. Omental wrapping has been shown to be highly effective in reducing both the incidence and, importantly, the severity of anastomotic leaks if they do occur. It acts as a sort of biological sealant and brings extra blood supply to the area.
A useful adjunct, then. Okay, to bring this incredibly detailed technical deep dive towards a close, let's quickly cycle back and summarize those 4 major anatomical hazards that really define the mastery or lack thereof of this operation, the things you absolutely cannot afford to get wrong.
Okay, the big 4 danger zones.
Thoracic duct. Remembering the necessity of secure, low ligation, 3 to 5 centimeters above the hiatus, and critically being aware of and looking for anatomical duplication. Remember, up to 3 ducts in maybe 65% of people to prevent chylothorax.
Duct ligation and variations. Number 2.
Aortic branches, meticulous ligation of those small, direct aortic feeder vessels supplying the esophagus without inadvertently injuring the wall of the aorta itself during dissection.
Protect the aorta. Number 3.
Airway injury. Specifically avoiding thermal dissection methods like dithermy right near the thin membranous trachea or main bronchi when taking out those subcarinal or parabronchial nodes, stations 107 and 109, because of the high risk of causing a post-operative fistula.
No burning the airway. And number 4.
Recurrent laryngeal nerve, RLN palsy. That relentless hazard lurking in the tracheoesophageal groove during the supra-ezygos and cervical lymphadenectomy phases, with its potentially devastating consequences for swallowing, voice, and breathing.
Duct, aorta, airway, RLN.
Got it. So we have the technical foundation laid out in incredible detail. Now let's try to synthesize this knowledge by applying it to a few high-stakes clinical decision-making scenarios. Okay, let's do it. Case 1. A patient presents with a locally advanced high squamous cell carcinoma. It's staged as T3N1M0, located relatively high up, say at 28-32 centimeters from the teeth. High node-positive squamous cell cancer. What's the standard treatment pathway here?
Okay, high location, squamous histology, node positive. Based on everything we've discussed, particularly the high propensity for neck nodal involvement in squamous tumors, and importantly, the results of the Krustin trial showing benefit for neoadjuvant therapy. The standard pathway would almost certainly be neoadjuvant chemoradiotherapy first,
Right.
followed by a 3-phase oesophagectomy. That means abdomen, chest, and neck dissection with a cervical anastomosis. That extended field of lymphadenectomy, especially including the neck, is considered mandatory to address the high likelihood of occult disease in the RLN nodes and the supraclavicular chains in this specific scenario.
Perfect. Okay, next scenario. Case 2. A patient with a bulky distal adenocarcinoma. Staging suggests T3N3M0, so a heavy nodal burden in the abdomen lower chest, but the PET scan also shows some suspicious uptake in a right supraclavicular node, station 104R.
Whoa, okay. Bulky adeno down low, but suspicious uptake way up in the neck. That supraclavicular node, 104R, showing uptake immediately changes the game. The absolute first step is a targeted neck ultrasound and fine needle aspiration, FNA, biopsy of that suspicious node.
And if that FNA comes back positive for adenocarcinoma?
If it's positive, then unfortunately the patient is classified as having systemic metastatic disease, M1. The prognosis becomes very poor, and curative surgery is almost always off the table. The focus would shift to palliative systemic therapy, given the extremely short median survival historically associated with positive cervical nodes in adenocarcinoma.
A crucial staging step then. But what if the FNA is benign? Maybe it was just inflammatory uptake on the PET scan. What's the next step in staging for this bulky distal OGJ-type tumor, especially before committing to major neoadjuvant treatment?
Right, if the neck node is benign, we still need to be concerned about another common site of spread for these distal tumors, especially those spanning the junction like a serotype 2. That's occult peritoneal disease. So the next step should be a diagnostic laparoscopy.
Look inside the abdomen.
Exactly. Perform peritoneal washings for cytology and carefully inspect the peritoneal surfaces. Only if the laparoscopy and washings are negative for cancer do we then proceed with neoadjuvant treatment, knowing we're dealing with a heavy but potentially still localized N3 nodal burden aiming for eventual surgery.
Excellent. Okay, final scenario. The classic postoperative complication that relies entirely on remembering the anatomy we've discussed. Case 3. A patient is recovering after esophagectomy, starts enteral feeding, and suddenly the chest drain output turns milky white. Pylothorax. What's the mechanism, and how does the treatment strategy shift based on the volume of the leak?
Right, the loci fluid is chyle. The mechanism is almost always a failure of that thoracic duct ligation during the operation. When the patient resumes enteral feeding, especially with standard feeds containing long-chain fatty acids, those fats get absorbed, packaged into large lipid particles called chylomicrons, and dumped into the lymphatic system via the intestinal trunk. If the main thoracic duct, or one of its major tributaries or duplications that was missed, wasn't securely ligated en bloc with the specimen, that chyle leaks out directly into the pleural space.
Makes sense. And the treatment?
Initial treatment is usually conservative. First, you immediately stop the standard enteral feed and switch to one containing only medium-chain triglycerides, MCTs. Why MCTs?
Because MCTs are absorbed differently, they go directly into the portal venous blood system, bypassing the lymphatic system altogether. So switching to an MCT-based diet drastically reduces chyle flow. You also monitor the patient closely for nutritional status and lymphopenia, loss of lymphocytes in the chyle.
And if the leak continues, or if it's very high volume from the start,
If the leak volume is large, and large is often defined as maybe over 1 liter per day, though it varies, or if it persists despite conservative measures, then surgical re-exploration is usually required. The goal is to go back in, find the leak point in the duct system, and definitively ligate it. This is generally best attempted relatively early, maybe within the first postoperative week, before extensive inflammation and scarring make finding the duct even harder. Sometimes a preoperative lymphangiogram can be attempted to try and pinpoint the leak site before going back to the OR.
okay, clear management strategy. So wrapping up, we have navigated the embryological origin. We've meticulously mapped the precise anatomical relationships, anterior, posterior, and that treacherous posterolateral course of the thoracic duct. We've synthesized the incredibly complex decision matrix that governs surgical approach selection, transthoracic, transhiatal, MIO, two-field, three-field, and we've drilled down into the technical steps and hazards, focusing on the duct, the aorta, the airway, and the RLN.
It's really about that synthesis, isn't it? The ability to instantly marry the textbook knowledge, like the precise location of the left RLN in the tracheo-esophageal groove, with the practical necessity of clearing the lymph nodes right next to it during a supraazygos dissection. That's what defines surgical expertise and mastery in this field. You have to know the steps, yes, but you must fundamentally understand why each step carries specific risks based on the anatomy.
Which brings us perfectly, actually, back to that fundamental challenge of standardizing any complex surgical technique, the reality of individual human variation. We spent a lot of time on the thoracic duct, and considering the fact that its system isn't always a single predictable tube, but often comprises 2 or even 3 separate major ducts in something like 65% of the population. How fundamentally does that very common anatomical variability challenge our current consensus on what constitutes the optimal surgical technique for duct ligation, and maybe even how we should monitor for chylothorax postoperatively? What really is the limit of standardization in surgery when faced with such a high degree of common critical anatomical variation?